So our next talk is surgical outcomes after pancreatic resection of screening detected lesions in individuals at high risk for developing pancreatic cancer.
Good morning. I want to thank the APA for the opportunity to present our work, and also to the Kenner Family Research Fund for the award that was granted. I have no disclosures. Per the SEER 2017, pancreatic cancer is associated with a 5-year survival rate of 8.2%. It will become the second cancer-related death by year 2020. 80% of patients present with metastatic disease at the moment of diagnosis. 5 to 10% of these patients have family history, either hereditary cancer syndrome or familial pancreatic cancer. Familial pancreatic cancer is 3 or more blood relatives with pancreatic cancer. At least 2 of these with first degree, needs to be first degree relative, and also any patient with at least 2 first degree relative are considered familial pancreatic cancer. No non-dominant gene. Cancer syndromes include Peutz-Jeghers syndrome, regardless of the family history. Familial atypical multiple melanoma syndrome, again, regardless of the family history. BRCA1/2 PALB2 mutation carriers with at least 1 first-degree relative affected. Lynch syndrome with at least 1 first-degree relative affected. We consider that these patients need screening, and we begin screening in Peutz-Jeghers syndrome at age 30, and patients with familial pancreatic cancer we recommend at age 50. Pancreatic cancer can arise from well-defined precursor lesions such as pancreatic intraepithelial neoplasia or PANIN, or macroscopic IPMN. Consensus guidelines for the surveillance of high-risk individuals have been developed. The goal of surveillance is to detect early-stage pancreatic cancer and high-grade precursors lesions. The aim of our study was to report the outcomes of high-risk individuals after pancreatic surgery for screening detected lesions. This study was performed using the prospective Johns Hopkins Cancer of the Pancreas Screening, or CAPS, cohort between 1998 and 2000, actually it's not 14, it's 2017. All patients underwent baseline endoscopic ultrasound and MRI or MRCP, and on a yearly basis or earlier pending baseline findings, we will alternate these procedures. CT scan, pancreas protocol CT scan was performed as needed to characterize lesions. Surgical outcomes were reported per the International Study Group of Pancreatic Surgery. We also reported new onset diabetes. Of the entire cohort, 354 asymptomatic high-risk individuals, including during a mean follow-up time of 7.6 years, were included. Of these, 48 with a mean age of 69, mostly males, with screening detected lesions underwent surgery. Of these 48, 42, which is 87%, had first-degree relative with pancreatic cancer. And almost 40% of the patients had smoking history. Also, of these, 12.5% of the patients had active smoking at the time of screening. These 48 individuals underwent a total of 57 operations, 48 initial and 9 second surgeries. Of these, 16 were Whipple procedures, 26 distal pancreatectomy, and 6 total pancreatectomy. 9 patients underwent completion pancreatectomy for a new lesion at the median of 3.8 years. Regarding surgical outcomes, overall median length of hospital stay was 7 days. Postoperative complications arise in 35% of the patients. 3 of these 48, which is 6%, had readmissions within 30 days. Of these, 1 was dehydration, 1 delayed gastric emptying, and 1 intra-abdominal infection. These all were managed conservatively. There was no 90-day mortality in this group. When we compare minimally invasive versus open surgery, outcomes were similar. The adverse events per type of surgery. In general, the group with total pancreatectomy had longer days of hospital stay. Overall complications were more prevalent in the Whipple group, as well as delayed gastric emptying. Steatorrhea was more frequent in the total pancreatectomy group, and weight loss more than 10 pounds was also more frequent in this group. All these differences were statistically significant. There was no difference in fistula, leak, cholangitis, site infection, readmissions, or the appearance of diabetes. Diabetes was seen in a total of 20% of the patients after partial resection. 10 of 48 of these patients require insulin pump. 13% of the patients with eventual total pancreatectomy developed severe dysglycemia. 1 required an ER visit, 1 hospitalization, and there was no severe hypoglycemic complications. We did the Kaplan-Meier, and we can see that at 1 year in the CAPS group, there was 90% survival, 85% at 3 years, and 60% at 5 years. When we compared to the SEER cohort, there was a statistically significant difference between the groups. We also performed baseline and postoperative health-related quality of life questionnaires to these patients, and there was no difference between pre-op and post-op level of satisfaction. This was actually presented as a poster earlier in this meeting. Regarding the screen-detected operated cancer patients, we had a total of 11 patients with cancer. Of these, 10 were resectable, and of the 10 resectable, 9 achieved R0 resection. 7 of these 10 patients underwent adjuvant therapy. As we can see, most of the patients presented with a mass, and the mean tumor size at the time of presentation was 2.7 centimeters. 2 of the high-risk individuals that underwent partial resection developed pancreatic cancer in the pancreatic remnant during continuous follow-up. Of the screen-detected high-grade PDOP precursors, we had a total of 10, 4 as PANIN3, and 6 IPMN with high-grade dysplasia. I want to show here that one of the PANIN patients presented with a main pancreatic duct stricture, mild dilation, and no mass. As you can see, the median tumor size at the time of screening and surgery was less than 2 centimeters in both groups. All these patients were alive at the time of the completion of this study. This is the patient that presented with a stricture, dilation of the duct, and no mass by EUS. This patient underwent an ERCP where we can nicely see dilation of the main pancreatic duct and a stricture. And the specimen showed a main duct PANIN3. What type of surgery we should offer to these patients? Total pancreatectomy versus partial pancreatectomy. This is a question that the answer is multifactorial. We believe it depends on the patient's health status, patient's preference, multifocality and multiplicity of lesions, and whether there is cancer or not. Still, we don't know the final answer to this question. In summary, pancreatic resection for detected lesions is associated with acceptable morbidity, no peri-op mortality, high patient satisfaction, preserve health-related quality of life. Surveillance of high-risk individuals can lead to detection of pancreatic cancer with high resectability, prevention of cancer because we are targeting to high-grade precursors, and it has been associated with improved survival per the Kaplan-Meier. Thank you very much.
Okay, this is open for questions. Here.
Thank you. Outstanding body of work. Shaunak Majumdar from Mayo Clinic. A couple of questions. One is, in the 2 patients that developed invasive disease in the remnant gland, what was the pathology that was resected?
These patients actually had benign IPMNs. Yes. And
so
then,
those were low-grade IPMNs that were resected?
Correct.
Okay.
But during follow-up, they developed cancer.
Sure.
Yeah.
And you reported that you had done completion pancreatectomy on a subset of patients. What was the indication? What prompted the decision to do a completion pancreatectomy? What type of lesions were removed?
They developed solid masses,
Okay.
and at the end, some of them had cancer, actually.
Do you know how many of those had a high-grade lesion or cancer?
No.
Okay, thank you.
You're welcome.
Next question.
Thank you. Ming from Beijing. I noticed there's several types of high-risk patients you mentioned. I'm wondering how you find the patients with pan-in, because they are hard to find. They are hard to find.
Correct. As you can see, this was all after surgical resection. Sometimes the EUSFNA did not even said this, but usually when during a screening, we see a solid lesion, or like this patient was very atypical because the patient only had a stricture and dilation of the main pancreatic duct. It didn't have a mass. We know when we see a patient with a mass, that patient will go to surgery. We discuss it in a multi-D clinic, but we don't rely only on the EUSFNA. These patients usually are offered surgery. Unless their health status doesn't allow it, they will go to surgery. So regardless of how they present, if there is a mass or a high, like a worrisome feature on a cyst, we will take these patients to surgery. And the final pathology is what gave us the panning 3. We agree it's very, very difficult. That's why screening, we believe, it's a good option.
Yeah, so I'm worried that we can see IPMN pre-operatively, and we can include it into the following up populations and to screening their worrisome features. But how about the pan-in patients? We can't find it.
Correct.
Before surgery.
So we did not have panning 3 as a pre-op diagnosis. These were all post-operative diagnosis. And again, we don't rely on the EUSFNA only. We discuss the patient in a multi-D clinic, and if the lesion has high-risk stigmata, worrisome features, these patients we will take them to surgery.
Okay, thank you.
Thank you. Next question.
Great work, and I think highlighting the consequence of these operations is important. I'll warn that any patient in a surveillance program that feels that something is detected, by definition, is going to have a high quality of life after, because they're going to feel very grateful, because the alternative would be to be gone. But putting things in perspective, you found 20% of these patients had cancer, about 20 or 25% of them had high-grade dysplasia in their IPMN or pannin3. That means more than 50% did not have anything.
Correct.
Right? So is this great for those patients who did, and looking at that survival curve is better, but we're really talking of a very small handful of patients, right?
Correct.
So is screening successful? Is this, Harold, we've won the battle, we're not harming patients because nobody dies after the operation? Or do we have a lot of work to do still to identify this?
That's a good
We
point.
struggle with this as well, right? Because
Correct.
you see these patients, 3 family members, you got a tiny little cyst. Are we going to take you and do a Whipple? Yes or no?
Correct. That's a great point. And Dr. Canto had this same discussion during her presentation. Unfortunately, we will never know because we're not going to not offer surgery to a patient that has worrisome features or high-risk astigmata. We don't have an answer, but we showed that there is increased survival in these patients.
And the ones who had cancer. But I'll bring this to the same argument just for the sake of the discussion. We grapple with the same things with IPMNs, right? So we're
Correct.
doing 50% of the operations don't have high-grade lesions, right? And this is failure.
Yeah. This is, I mean, it's something. I know there is a lot of work, but we believe we're helping patients, and obviously we discussed with the patients too, and they made the ultimate
So
choice.
it's great work, and thank you.
Thank you very much.
Thank you so much. Last question.
This is Miyasaka from Kyushu University. You have 9 patients who underwent total remnant pancreatectomy. And how often do you perform the post-operative surveillance after surgical resection, partial resection?
Of the total pancreatectomy patients?
No, partial pancreatectomy. So how often do you perform screening?
It depends, but in general, any patient that it's a high-risk individual will have EUS alternated with MRI every 12 months.
Every 12 months.
If the
yearly.
patients have any suspected lesions, we will do like a shorter surveillance. If it's we discuss all these patients in a multi-day clinic, but if the patient has like a suspected possible lesion, we will do a shorter surveillance, like in 3 months. And if this patient needs, is a candidate to have surgery, that patient probably will go to surgery. If not, we will continue surveillance.
Didn't you miss patients? So patients who are found unresectable during surveillance.
Can you repeat?
You don't have any patient who have unresectable remnant pancreatic lesion.
We had 2 patients of the entire cohort who had cancer in the remnant. Only 2.
Only 2.
Yes.
Thank you.
Okay, thank you so much. All right. So due to a